Hello everyone, welcome back. This month is going to be a follow-on for POCUS. This is going to be POCUS Part 2, a follow-on from POCUS in Flight Part 1 we did back in September of 2025. We spent a significant amount of time over the last several months focusing on just how to obtain views with the ultrasound, how to put the probe to the skin, and just trying to identify certain landmarks, certain structures within the body. This month and going forward in our training and at HPS, we're going to be really diving into the when should we actually be performing these exams and what clinical scenarios, what indications do we have to actually break out that probe in the back of an ambulance, in the flight, or in a hospital room to perform certain assessments. We're going to talk a little bit about the eFAST exam, introduce something called the rush exam, and we've filmed a couple scenarios for you guys, just going over or demonstrating different scenarios of when we recommend and when we think the ultrasound probe is going to be most useful for us in our day-to-day live running calls. We're going to start off with a little 12-15 minute piece of content from Travis Weber. It's his first month helping us out, and so you guys are going to see him next. Appreciate everything y'all do, and thanks for being here.
Hi everyone, my name's Travis. I'm a flight nurse with CareFlight, and today we're going to start our discussion with HEMS POCUS, that's point of care ultrasound. And more specifically, we're not going to go into how to do these exams, but why we do the exams. There's tons of clinical applications for the use of ultrasound, but today we're going to kind of narrow it down to a couple different ultrasound protocols that we can use every day on the job. So more specifically, what we're going to be talking about is the clinical applications for the use of ultrasound in the field, our types of exams that we have at our disposal, logistical issues that we might need to overcome during transport and in the field, and then documentation of our ultrasound exams. All right, so why would we use ultrasound, especially during transport? So there are many limitations that we might have to overcome, especially during transport, in the back of a helicopter. Things like engine noise, vibration, limited access to our patients. These visual and auditory limitations can be overcome with the use of ultrasound. Now, ultrasound has been studied in the HEMS environment, and upwards of 30% of eFAST exams in the field have been shown to alter clinical decision-making, and transport destination have been changed in approximately 20% of eFAST exam cases. Now, on a positive eFAST exam, our ability to treat the patient in the field could certainly be limited. However, positive eFAST exams have been shown to drastically alter the time to surgery by upwards of 35 minutes once arriving at their destination. Now, it's important to point out that initial quick exams are essentially what we're going for here. Whether that's prior to loading the patient into the helicopter or during what I like to call dead time in the air when it feels like there's not much else to do. So utilizing the ultrasound at the appropriate time is important here. Whether that's prior to loading the patient or in the back of the helicopter, these things do matter. So the eFAST exam is just a rapid assessment that we utilize here at CareFlight and at other HEMS programs. And essentially what it does is it allows us to rapidly assess the patient for things like internal hemorrhage, cardiac tamponade, as well as cardiac squeeze, and then our lung points as well for things like tension pneumothorax. So what does a positive FAST exam look like? So if we're looking at the Morrison's pouch, we're looking for anechoic or fluid in that space in the peritoneal cavity. The transplantic pouch, which is behind the spleen, which also, again, we're looking for anechoic or black fluid in that area. Coupled with either hypotension or an MSI greater than 1.3, this is going to clue us into transfusing these patients. Additionally, with a positive FAST exam, alerting the receiving facility, especially a level 1 trauma center, is going to clue them in to the possibility of rapid surgical intervention. The next exam we're going to discuss is the rush exam, or the rapid ultrasound and hypotension exam. Now, this exam focuses on the pump, the tank, and the pipes. So when we're assessing the heart, the things that we're primarily looking for, at least initially, is there fluid surrounding the heart or the pericardial sac? Is the heart muscle contracting appropriately? So, and this is really a subjective finding that is graded good, intermediate, or poor. So you look at the heart, you see cardiac contractility, but it's limited. It looks poor, sluggish. That can kind of clue you into like late stages of sepsis or heart failure, essentially. And these types of patients are likely not going to do well with a fluid bolus. So starting things like inotropes and vasopressors are important in these cases. So when we're looking at the IVC, in a normal patient who's not being mechanically ventilated, your IVC should be right around 2 centimeters. During inspiration, we should see a collapse of approximately 30% of the IVC. If you see a collapse greater than approximately 50%, it's indicative of hypovolemia. Now, if the IVC is larger than 2 centimeters and does not collapse with inspiration, then it clues us into things like heart failure and obstructive shock. Now, this exam is important to follow up on. So if you're going to administer a fluid bolus, for example, you can then reassess your IVC following the fluid bolus prior to giving additional fluids. Now, all this kind of changes if the patient is being mechanically ventilated. What you're going to see is more than likely a larger IVC because of the change in intrathoracic pressure. And what's important in this exam is that you monitor the IVC for roughly 10 seconds during inspiration and expiration. And if you see a large change in the diameter of the size of the IVC, it could be indicative of hypovolemia. So the last part of the exam is assessing the pipes. And for this discussion, I'm essentially going to focus on the aorta. So what you're going to do is you're going to find the aorta, and it should be pulsatile on the exam, and you are going to measure the size of the aorta, and if it's larger than 3 centimeters, it's potentially indicative of abdominal aortic aneurysm. Now, coupled with hypotension, this exam finding is indicative of rupture, and blood products should be administered.
I'll place it in transverse orientation just below the xiphoid process to start. Here I can identify clearly my vertebral shadow, and just above it, the pulsation of the aorta. Trying to maintain pressure and keep it going all the way down towards the legs, decreasing depth as I go to maintain a clear image. I can visualize the pulsating aorta all the way down towards its bifurcation into the iliac vessels.
To kind of sum it up, you're going to utilize this exam when you show up, your patient's hypotensive, you don't exactly know why they're hypotensive. So you pull out your ultrasound, and this kind of guides you into, for lack of a better term, a diagnosis of why they're hypotensive. Another situation that you might find yourself in is you have a patient who's in respiratory distress. You know that they've got COPD, perhaps they've got some kind of heart failure underlying condition as well, and you don't exactly know why they're having the shortness of breath. This would be a perfect time to break out your ultrasound, and what you're looking for on this exam is a normal finding like A lines or potentially B lines, pneumothorax, things of this nature. So what do I mean by a B line? A B line, some people call a lung rocket. They're vertical lines that, or a comet that shoots down the lung field. And these are indicative of pulmonary edema. Another caveat to finding a B line on a ultrasound exam is that B lines are never present in pneumothorax. So this could be, so you're potentially ruling in pulmonary edema, but you're also ruling out a pneumothorax in this case. If you find A lines, those are normal, so you can kind of move on to your exam, or in this scenario, you're leaning towards COPD, something along those lines. So essentially, the ultrasound is going to clue us into whether or not the respiratory distress is either cardiogenic or non-cardiogenic. This is really more of like a specialized application, just kind of one that I thought was pretty cool. You can actually take the ultrasound like post-intubation or perhaps at bedside in a hospital, and you can place it over the patient's trachea. And what you're looking for is a hyperchoic, meaning a super white or bright interface on the screen. That's indicative of the endotracheal tube being in the proper position, or in this case, the trachea. Now, there's something called the double track sign, which is essentially a enlarged esophagus sitting next to a normal sized trachea. So this kind of just emphasizes the idea that the ultrasound that we carry offers us a wide variety of uses, not just eFAST, not just Rush. There are many clinical applications, and learning about them can be interesting and beneficial for the patients that we see. Okay. So after you've completed your call, you're working on your chart, just make sure to upload your ultrasound exams. These can be used not only for charting and chart reviews and stuff like that, but ultimately they can be used as a learning tool for the rest of us at the company. And the thing that's going to help improve everyone's outlook, I think, with the use of ultrasound is people becoming more comfortable with it. So break it out, use it, have fun with it. There's a wide variety of clinical applications for this product. All right, so thanks for watching. And now what we're going to do is we're going to break off, and we're just going to kind of discuss some clinical applications, or rather clinical scenarios where you might want to utilize an ultrasound. Thanks a lot.
Beautiful. Strong work. All right, we're being dispatched to a 6-something-year-old female with shortness of breath. It's going to be a scene call. We're not really sure what's going on. Going to hop in the back, take a look, see what's going on, try and figure it out. First things first, going to get a report from the paramedic on scene and see what we're dealing with today. Let's go ahead and hop in and find out what's going on. Knock, knock.
How you doing, guys?
Hey, how you doing, man? What's going on?
Hey, thanks for showing up.
Yes, sir.
Just getting her hooked up to a breathing treatment here.
All right. How are you doing, ma'am?
Okay.
Working hard?
Yeah.
Yeah? Okay. All right. You just keep focusing on that breathing. Don't do too much talking for me. Paramedic back here is going to tell me what's going on, okay? All right, man. What you got?
All right, so this is a 45-year-old female. She called EMS because she was having some difficulty breathing. She's got a significant history of smoking, as well as prior MI.
Okay.
She's kind of been maintaining her oxygen saturation with a non-rebreather. We currently started a breathing treatment on her. She says this kind of started a couple hours ago, and it's kind of progressively gotten worse, but she's really struggling to get some air. This is pretty much all we've done.
Okay.
She's got no medical history, or no allergies, and her last set of vitals, she's got a heart rate of 120, oxygen saturation on room air was about 80%. She's currently 95.
Nice. I like it.
Blood pressure was 140 over 72.
Okay, cool. All right, have you given her anything so far?
Just started an albuterol.
All right. All right, man, so have you taken a listen to it all yet?
Yeah, I did. It sounded like she's got some wheezing. I didn't hear any crackles or anything like that.
Okay. All right. Ma'am, has this happened to you before? Okay, what normally happens when this happens? Do you just take you to the hospital or, okay. Do you take any medications for this? Okay, have you ever been told you have heart failure? No? Do you have asthma? Do you have COPD? Okay. How's your breathing feel right now?
Not great.
Not great? Alrighty. Since you already listened to your lungs, I'm going to do one more exam real fast, just with our ultrasound right here. I'm going to take a couple pictures of your heart using this, just to see if we see any fluid on your lungs or anything that might kind of help us decide what we're going to do. Alrighty. Did you do a 12-lead on her as well?
Yeah, we did. No significant EKG change.
All right, ma'am. What's your name?
Katie.
Katie. Hi, Katie. Nice to meet you. My name's Dylan. Are you able to sit back at all, or does that make it too hard for you to breathe? Okay. I'm going to step over to the other side of you right here, okay?
Katie, we're going to lay you back just a little bit.
All right, so if you don't mind, I'm just going to put a little bit of jelly right here and right over here. Like I said, we're just looking at your lungs, looking to see if you have any fluid on there. Do you take something called a water pill, maybe like Lasix, that makes you pee or anything? No, nothing like that? All right, here we go. Cold gel right here, okay? So first things first, and I'll kind of show you what I'm doing here as well. Alrighty. I just have this little ultrasound. It's going to take a picture, show it on my screen. All right. I'm taking a look at your lungs, and I'm just looking for anything maybe that looks like something like pulmonary edema. All right. So Travis, you see here we have good A lines.
Yep.
For those looking at home, so we're going to look at 2 points of view, or we're going to look at 4 total points of view, upper and lower fields bilaterally. Right here we have A lines. All right, sweetheart. You keep breathing, you keep doing your thing. I'm just going to move your hair away right there. And take a look over here as well. All right. And do you mind if I pull your shirt up just a little bit right here on this side? Thank you very much. And just a little bit more jelly, okay? All right. And there's the liver. I'm going to come up just a little bit higher so I can see your lungs, okay? And looking right here, we do have a little bit of pulmonary edema. So just so you can see what this looks like as well, this is going to be just 3 or more of these little comet tail views. Kind of looks like light shining down from a stained glass window shining through, and that just tells us you have fluid on the lungs, okay? Going to take one more look over here as well. And yeah, pretty much seeing the same thing right here as well. So we have some basal pulmonary edema, some fluid collecting at the bases of your lungs, okay? So good news is, that tells us exactly what's going on with you and how we're going to fix it. What's in y'all's protocols for treating pulmonary edema, man?
We can give Lasix or nitroglycerin.
And let me wipe this off for you. All right. All right. So yeah, I think we're going to go ahead and do a couple medications. I'll wipe this off for you right here as well, okay? I don't want you walking around getting all dirty. I'll plug this back in for you. All right. So did Travis here already tell you that we're going to be taking you in a helicopter? Okay, have you ever been in a helicopter before? All right, it's a lot of fun. I think you'll really enjoy it, okay? Once we get you in there, we might put you also on another machine that's going to help kind of open up those airways where the fluid is collecting. And then we're going to start, we already have an IV right here. I'm going to connect an IV medication called nitro to it. And then we might even give you some of that medication I was telling you about called Lasix to help you pee off some fluid and remove some of the fluid from your lungs, okay? At any point in time, if you feel like you're having trouble breathing or anything like that, we're going to be sitting right behind you in the helicopter. Just kind of wave your hands around and we'll help you.
All right, so in this scenario, we are transporting a 55-year-old female patient. We're going from a small hospital outside of Dallas to a larger hospital for cardiology consult for heart failure. Patient was aggressively diuresed at the sending facility and is currently in the back of our ambulance and is now becoming increasingly hypotensive.
All right. All right, what you got going on over there, man?
So it looks like her blood pressure has kind of been dropping for the last about 10 or 15 minutes since we picked her up. Her last pressure was 85 over 50.
Okay.
But if you remember, she started around like systolic 130.
Okay.
So I think something might be going on.
What's her heart rate right now?
Heart rate's 120.
Okay. Ma'am, how are you feeling?
Okay.
You doing okay? Just hanging out?
Tired.
All right. Sorry we're stuck in traffic.
It's okay.
Normally we go by helicopter, but bad weather today, so we had to go by ambulance. I know it's really bumpy back here. I'm just going to check down here. I'm looking for any swelling or anything. Do you normally have a lot of swelling or anything on your ankles? You do have a lot of swelling a lot of times? Okay. This happened to you quite a bit. Are you having any trouble breathing or anything right now? Okay. Well, your blood pressure is just a little bit low, a little lower than we like. I'm going to take a quick look at your heart with the ultrasound right here, okay? And just kind of see if I can figure out what's going on, maybe what our different treatment pathways are going to be. Sounds like at the other hospital they gave you a lot of medicine that makes you pee a lot. Have you been peeing a lot the last couple of days? Yeah, a whole bunch. I'm gonna lay this down right here, okay? And so sometimes it might happen that they make you pee a little bit too much, and so we might need to give you some more fluids back. And if that's not the case, then we're actually gonna need to give you some medicine to make your heart squeeze a little bit better, okay? All right. So if you don't mind, I'm gonna do a little bit of jelly right here on your belly, okay? And first things first, I'm just going to come in here and I'm just looking at your heart, alrighty? All right, let me see if I can get a good view of that. And there's your heart beating right there. If you want to see what your heart looks like, I'll let you see right there real fast. So that's your whole heart. It looks like it's beating really, really well, actually, really, almost even hyperdynamic, what we would call it. So considering what you got going on, I'd just call that pretty decent. I'm going to flip over here real fast. I'm going to take a look at her IVC. And we're just going to see if it looks like it's over or underfilled. All right, so I see the IVC right there kind of coming out where it comes out of the right atrium. Scan over just to make sure I'm not looking at the aorta. There's aorta running at the bottom of the screen, right around here. All right, dear, there's your liver. And once I get that in view, will you sniff real hard for me? Okay, that actually did collapse all the way down. So, one more time, when we get that view again, I'm going to ask you to sniff one more time in just a second, okay? All right, will you sniff for me again? All right, and one more time. Perfect. All right, so I'd say the IVC looks pretty collapsible, actually. The walls of the IVC are pretty much almost touching themselves. Heart looks pretty hyperdynamic, actually. I'm going to wipe you off here. All righty. Thank you, ma'am. I don't think she needs any pressors or inotropes at the moment. I think we should start out with a little bit of fluids.
Yep.
You can go like 250 or something.
Yep. And we can always reassess after we get some fluids.
Yeah, for sure, absolutely.
Like the blood pressure is a little bit better. Last pressure was 100 over 62.
100 over 62. All right, my friend, I'm just going to take one last look. We gave you just a little bit of fluids here to kind of help your heart pump a little more effectively. I'm just going to take one more look and see if it worked here, but your blood pressure looks really good, okay? And let me rotate around. Do that sniff for me again. All right, that's looking a little bit better. Give me one more. All right, my friend, that does look a whole lot better, actually. Your IVC looks nice and full up. I think we're all right. You feeling okay right now? All right, we're going to get out of traffic here soon, I promise. Sorry, I don't have any canasta or anything we can play well on the way there, but we'll figure something out, okay? All right, anything else you want to do, man?
Nope.
Okay. All right, how's it going, y'all?
Hey, thanks a lot for coming.
Yeah, what you got going on, brother?
Yeah, this is a 65-year-old. She had a cabbage procedure done about a week ago.
Okay.
It sounds like she just got discharged from the hospital either yesterday or the day before. She was feeling short of breath, as well as a little bit dizzy.
Mm-hmm.
We showed up on scene. Her oxygen saturation was about 85%. Her blood pressure was in like the 70s.
Okay.
We started an IV. We were getting ready to start fluids on her, but that's about all we've done.
All right, sounds good, man. First things first, can we get her on some oxygen then if she's down about 85? Ma'am, how are you doing? Yeah, okay, all right. When did this all start?
some oxygen on your face. Thanks.
All right, we're just gonna put a little bit of oxygen on to help you breathe, okay? When did this all start for you?
A while ago.
A while ago? Okay, you just had surgery on your heart last week, is that what I understand? Okay, what'd you have done, a cabbage? Yeah? All right, dear. I'm just gonna take a quick look at you, figure out what's going on. Hey man, were you able to do a 12 lead on her?
Yeah, we did a 12 lead. We didn't find any ST changes. It looks like sinus tach.
Okay, all right, man. All right, how's her oxygen coming up with that non-rebreather on?
Oxygen is 92%.
Okay, can you uncross your legs for me here, sweetheart? Thank you very much. All right, is your chest hurting you at all? No, nothing, okay. Just feeling weak, a little dizzy? All righty. All right, man. I'm gonna take a look at her heart real fast, see if it's pumping or not. With like recent cardiac surgery as well, kind of concerned for maybe like some tamponade, some like slow bleeding building up around the heart. So we're gonna take a look at that before we do those fluids that you were talking about to fix the blood pressure. I wanna make sure that that's just kind of the most appropriate intervention for her, okay? And ma'am, what's your name?
Katie.
All right, hi Katie, my name is Dylan. Like I was just telling him, I'm gonna use this right here just to take a quick look at your heart, a picture of your heart and see what's going on. It's gonna kind of help guide us and just figure out what it is that we need to do, okay? Alrighty. All right. So if you don't mind, I'm just gonna put a little cold jelly right here on your belly and take a look at your heart, okay? All right, here we go. All right, so there's your heart beating and squeezing right there. Actually, a really great view of it all around. I don't see any effusion. I don't see any blood collecting around it, which is good, all right? That means that the surgeon did a good job at kind of closing everything up in there. However, man, it does look like it's beating a little weak. It looks pretty hypodynamic. So I'm thinking instead of fluids, we want to start like an inotrope. What'd you say her blood pressure is right now?
Blood pressure is 75 over 40.
Okay, so we definitely want an inotrope, but we definitely want a pressor as well. I feel like if we did dobutamine right now, I'd probably tank her pressure even more potentially. So I'm thinking we could do dobutamine and levo combined. I'm thinking we just go straight to epi. What'd you say her heart rate is right now?
Heart rate's 110.
Okay, dobutamine and epi are gonna have the same effect on heart rate, so I'm fine with doing epi. I'll take these fluids with us in the helicopter. We're not gonna use them quite yet. I'm gonna set these on your lap, okay, ma'am? Did Travis here tell you that you're going in a helicopter? No? Okay, well, we're about to put you in a helicopter, all right? It's gonna be a lot of fun, I promise you'll like it. Once we get in there, I'm gonna connect some medication to your IV. I think it's gonna help you get feeling a lot better, all righty? Man, is there anything I'm forgetting to ask, or we good to go? All right, man, we're gonna get her out of here and get you back to your surgeon and see what's going on, okay? All right, so for this scenario, we're being dispatched to a level 3 trauma center for a 30-something-year-old female that they need to fly downtown to the sister level 1. All we know is that she is currently intubated and she's being flown for traumatic injuries. Let's go inside and take a look and see what's going on. Knock, knock, care flight.
Hey there, thanks for coming.
Hey, what's going on, brother?
Yeah, so this is a 32-year-old female. She was involved in a motor vehicle accident. Unknown rate of speed. It sounds like she was driving an older model vehicle, a pickup truck. When she went off the road into a ditch, there was no airbag deployment, and it looks like she possibly hit her head on the steering wheel.
Okay.
So we were kind of working her up for a head injury. She was alert and oriented on scene. She came in the hospital. She looked pretty good, and she was also alert and oriented for us. Our x-rays were all negative. We were not able to do a CT scan.
Okay, gotcha.
But then about 30, 40 minutes ago, she started becoming a little bit altered.
Yeah.
So the doctor decided he wanted to intubate for airway protection.
Okay, gotcha.
Since then, she's become more hypotensive. She's only on a little bit of propofol right now.
Okay.
But we're still kind of struggling with that blood pressure there.
Okay, sure. So when she got here, her blood pressure was normal?
Blood pressure
Vital
was
signs
normal.
look great?
Correct,
Okay, we just
yes.
thought it was like a head injury, is what it sounds
Yes,
like?
correct.
All right, man, sounds good. On your exam, did you find any issues? Like
The only
abdomen?
injury that we really saw was laceration to her head, and that was about it.
I got you. Abdomen soft, non-distended, pelvis was stable, all those kinds of things.
Yeah, it was.
No trauma.
Correct.
All right, man. And what time did y'all intubate? How long ago was that?
About 20 to 30 minutes ago.
Okay. All right. And when you looked at her pupils, were they normal?
Pupils were equal and reactive,
Okay.
yeah.
All right. So like maybe like a concussion or TBI, but we're not really sure.
That's kind of what we were thinking,
Okay,
yeah.
all right. You said the CT was not able to be done, so we can't rule out any abdominal
Yeah, our
trauma or
scanner's
anything?
down.
Okay, man. All right. I'm going to do a quick ultrasound real fast. I just want to make sure with the blood pressure like this after a trauma that there's not actually some internal bleeding going on or any kind of hemorrhage. So we'll take a look here in just a second, okay?
Okay.
And how much propofol do you have her on right now?
She's only on 10 currently.
Okay. All right, so I'm just going to do a quick little fast exam. Take a look at a couple of things. And sorry, sweetheart, I know you can't hear me. I'm just going to take a quick look at your lungs right here, okay? All right, so looking here on my ultrasound, everything looks good. With breathing, she is, yep, I have good lung sliding there. I have good lung sliding there. Okay, so that hypotension, I mean, doesn't look like she has pneumo, so I don't think any of that, any of the hypotension is coming from like a tension pneumo or anything like that, okay? I'm gonna move your hands real fast. And we'll grab this towel over here. Sorry, brother. No, I'm all up in your space. I'll get her out of here real fast, okay, man?
Okay.
I'm just gonna take a quick look at her belly. So right here, this is what we do when we wanna look at the heart, and then we also wanna look kind of behind the liver, looking to see if there's any bleeding and any internal hemorrhage, okay?
You know, she did say she had a little bit of abdominal pain when she came in.
Okay, all right. But it was never like distended or anything like that?
No.
Okay. All right, heart's beating well, no pericardial effusion, everything there looks good. Gonna move down here, look at the, this is called the Morrison's pouch down here. We're just looking down here behind the liver, where the liver and the kidney meet. And yeah. So right in here, we do have a little bit of blood collecting behind the liver and Morrison's pouch.
Okay.
So definitely a positive fast exam there. Gonna continue down and just make sure we don't have any bleeding anywhere else. Right here, looking behind the liver. Or behind the bladder, I'm so sorry. And nothing back up in there. Alrighty. Well, I think at least with seeing that blood collecting in Morrison's pouch, that's enough to tell us that she is bleeding. This is more than just a head injury, man.
Okay. Do you guys carry blood?
We do, yes, sir. And yeah, absolutely no fault on y'all because, you know, like you said, your CT machine is down. No way for you guys to know this. Oh, we do carry blood. We didn't bring it in with us. We keep it in the helicopter. So we're going to package her up, get her out of here. We'll get that blood started in the helicopter.
Okay.
It'll be about a 12-minute flight if you want to call and report to them, let them know that we're on the way, that we do have a positive fast exam, and that we're going to be starting blood products for them, okay? If they want to let the trauma team know. All right, we'll get out of here. Good afternoon, man. What you got going on?
Hey, thanks for coming. This is a 75-year-old female. We're transporting her because she's kind of been deteriorating over the last couple days. Mm-hmm. She came in initially with what seemed like a UTI, as well as hyperthermia. She's been on antibiotics for the last 3 days, but this morning she started becoming a little bit more hypotensive. We recultured her, and she's now currently receiving her second IV fluid bolus of 1,000 liters.
Okay.
Still hypotensive, but yeah, we're suspecting septic shock, but we're not entirely sure.
Oh, cool. What kind of meds do you have her on right now?
She's currently just getting the IV fluid right
Just
now.
IV fluids, okay. Yep. How long has she been soft like this, like hypotensive?
Probably the last like 3 or 4 hours.
3 or 4 hours, okay.
The first fluid bolus that she got seemed to help her pressure a little bit, but now she's just kind of circling, it looks like.
Okay, I got you, man. Ma'am, how are you doing, sweetheart?
Oh, okay.
You're doing okay? You're feeling good? Yeah. She's kind of your normal state of health?
Great.
Yeah, great. Okay, I love that. All right. Well, hey, my name's Dylan. I'm a flight nurse, okay? We're going to get you checked out, see what's going on, maybe try and get your blood pressure up just a little bit. And then we're going to take you in a helicopter to a bigger hospital downtown. Get you to a helicopter. Yeah, it's a lot of fun. I think you really like it, okay? All right. If you give me just a second to get some things ironed out. All right, man. Have y'all run any labs on her or anything?
Yeah, we did. White blood cell count's a little bit elevated, but nothing crazy. Her lactate was also just a little bit elevated, at least this morning when we drew labs. H&H was fine, and her electrolytes were okay as well.
Okay, I got it. And you've already given her a decent amount of fluid and she's still pretty soft. Ma'am, do you have any past medical history of like heart failure or anything like that? No, no breathing problems typically? Pretty healthy usually? Okay, all right. Just a little infection sometimes gets to you, you know? It happens to the best of us. Yeah, I mean, you said like ABGs, pH, everything's normal, like not acidotic?
Yeah.
Nothing? All right. I don't really know why she's so hypotensive. I'm thinking I'm probably just going to want to start some pressors on her, but I want to make sure that, like, especially with those fluids, that her heart's kind of tolerating everything, all right? So, ma'am, if you don't mind, I'm going to use this fancy little thing right here. I'm going to take a look kind of at your heart and at your belly a little bit and see if I can figure out what's going on with you, okay? Alrighty, and I've got a little bit of jelly that I'm going to have to use as well, okay? It's going to be a little cold, but I'll get it off you as soon as I can, okay? All right, and if you don't mind just this oxygen, if you feel like you don't need it, you can get it out of the way, but, you know, the doctor says it's good for you, all right? Now, you not about it? Here, let me just get that. Let me just toss that away for you, okay? All right. All right, I'm going to pull up your shirt here for just a second, okay? And a little bit of cold jelly. And here comes the probe, all right? So first things first, I'm looking at the heart right here, looking to see if it's just even squeezing very much at all. And it looks like it is. It's squeezing super well. Well, actually, I don't know. That looks a little... You said you don't have any history of heart failure or anything like that? All right. Well, I'm not going to tell you that you are either, all right? But I'm going to tell you that I might give you a little bit of medicine to help it squeeze a little bit better here, okay, in just a second. I'm going to take a look at one other thing real fast. I'm just going to rotate the probe just like this so it's kind of pointing at the feet. And I'm going to look at something called your IVC, okay? And I'm just looking to see if there's any fluid in it, how it's looking. And that actually looks super distended. So the nice nurses here, they actually gave you some fluids to kind of help bring your blood pressure up. And it looks like they gave you just the right amount. Because this vessel called the IVC is looking nice and plump. So we definitely don't want to give you any more of that, okay? Yeah, in fact, I think between that, heart's looking just a little weak. Her heart rate is just a little bit high. So, you know, that doesn't, you know, especially with the AFib and everything, it doesn't make me super happiest about starting some epi. But I'm thinking maybe a little bit of low-dose epi and a little bit of low-dose levo, probably the best thing for her. In this rush exam that I just did, you know, normally we would also look at if we really don't know why the patient is hypotensive, we'd look at the aorta as well. But I don't think there's any damage going on with her aorta or anything right now. I think we pretty much have our answer here that fluids are good. We're definitely not going to continue any more of those. I think her heart needs a little bit of support, and I think her vasculature needs a little bit of squeeze. Ma'am, I'm going to get you started on a medication here called, I'm going to do two of them. I'm going to do one called Levofed and one called epinephrine, okay? We're going to do low doses of both of those, kind of help your heart squeeze and kind of help your vessels get a little tighter to bring your blood pressure up, okay? Man, is there anything else I'm forgetting to ask you, or do you think you get a pharmacy to grab those meds for us?
Yep, I'll get them.
Cool. I think we'll get those ready, get those running, and then we'll get out of your hair and get her taken downtown.
Thank you.
Cool.